A patient with head injury has BP 180/60, heart rate 48 per minute, and irregular respirations. Okay, read the question carefully. You can get hint from the questions itself. Okay, so what is the priority interpretation? Just combine all these things. What do you remember, or what you should know is these are the symptoms of a specific condition. Okay, let me tell you. So the first option is hypovolemic shock, B neurogenic shock, C Cushing triad, D yearly septic shock. Okay, first one, hypovolemic shock. It won't come because in case of hypovolemic shock you will be having tachycardia plus hypotension, but here it is bradycardia plus hypertension, so it won't come. Next is neurogenic shock. In yesterday's video I think we have seen about it. Neurogenic shock will be having brady plus hypotension, but here hypertension. Brady is there but hypertension, so neurogenic shock won't be coming. And yearly septic shock. Septic shock la we will be having fever plus hypertension and tachycardia. Okay, not brady, tachy. So this is also will be coming, and the answer is Cushing triad. Okay, because the patient is having head injury, and Cushing triad means a patient will be having hypertension, that is wider pulse pressure will be there. Wider pulse pressure, hypertension, 180 minus 60 is like 120, right? So wider pulse pressure, the patient will be having hypertension plus brady plus irregular respiration. So all these symptoms will be there in Cushing triad. A burn patient 60 kg arrives 2 hours after injury. Using Parkland formula, how much fluid should be given in first 8 hours if TBSA, total body surface area, is 40%? So as we know, Parkland formula, as yesterday we have studied, 4 ml into kg, body weight into TBSA, right? So 4 into 60 into total body surface area is 40. So just multiply it, you'll be getting 9,600, right? But in question they have asked in first 8 hours. In first 8 hours. So we have to divide it into in the first 8 hours we'll be giving the half of the fluid. Okay, 9,600 ml divided by 2. So the half of the fluid will be given in the first 8 hours, and next half will be given in the 16 hours. Okay, so first 8 hours la you'll be giving, if you divide it, it is 4,800. So 4,800 ml in first 8 hours. See, this option is also correct, but here they have given clearly 4,800 ml in first 8 hours. So we can choose this. Okay. Which ABG indicates fully compensated respiratory acidosis? So on seeing this question, we'll get, we might be thinking it is difficult, right? While seeing all these numbers, but it is very, very, very simple question, because just to see, in the question they have asked fully compensated. Which ABG indicates fully compensated respiratory acidosis? You leave that. Fully compensated means, what is the meaning of fully compensated? The pH should be in the normal range. pH should be in the normal range, and that is what called fully compensated. I have already taken class on ABG, right? Clearly I have taken. So if you didn't see, and if you need clear understanding, kindly see that video. So here let me clear you with this idea. Like pH, if it is normal, then it is fully compensated. Okay, what is the normal range of pH? 7.35 to 7.45. So pH should be in this range. If it is inside this range, then it is fully compensated. Tell me now in which option pH is within the range. Option A, no. Option B, S. Okay. Option C, no. Option D, no. So the only option B. B is the right answer. And if you want to check whether it is respiratory acidosis, see carbon dioxide PaCO2 is 55. Yes, it is above the normal range. It means acidic. And if PaCO2 is more, it is related to respiratory. So respiratory acidosis, and then HCO3 is 32. So it is trying to compensate, and anyway it is fully compensated. So answer B is the right one. A patient on heparin infusion develops gum bleeding. APTT is 1/22. What is the immediate action? So on heparin infusion and active bleeding is there. Okay, so anyway the dosage is more, right? Like now we have to stop the infusion, that is important, but active bleeding is there, so we can't just stop the infusion and be quiet, right? We have to give some antidote so that the action should be reverted, right? So antidote for heparin is protamine sulfate. So administer protamine sulfate. Okay, and you have to know if the patient is given heparin, okay, for any treatment, heparin infusion or heparin therapy is going on, we need to check the APTT levels. Yes, in case of warfarin we'll be checking the PTINR. Okay. Okay, so here the answer is administer protamine sulfate. A postpartum woman develops sudden dyspnea and chest pain. Dyspnea and chest pain. Okay, something related to lungs. Yes. What is the priority suspicion? So first one is amniotic fluid embolism. In case of amniotic fluid embolism, patient will be collapsed. Okay, patient will be collapsed and they'll be having DIC. Okay, internal bleeding also will be there. Next, pulmonary embolism is associated, right? Dyspnea and chest pain, pleuritic chest pain. Pneumothorax is unrelated to this condition, and fluid overload will be having crackles, all those things. So the answer is pulmonary embolism. So in case of pulmonary embolism, patient will be having dyspnea and chest pain. In DKA, diabetic ketoacidosis, which electrolyte appears elevated initially but total body stores are depleted? Okay, so here we have to check only sodium and potassium, because magnesium and calcium is unrelated to DKA. Only sodium and potassium. In case of DKA, sodium will be low always. So in case of DKA, will be giving more fluids to the patients, right? So sodium will be diluted, right? So in case of DKA, sodium will be low, okay, due to the dilution. But potassium will be higher. Potassium appears elevated. Why? Because DKA occurs due to severe insulin deficiency. So insulin will be low. Glucose like hyperglycemia will be there. If insulin is more in the blood, if insulin is more, like if insulin enters the bloodstream, then this potassium will go into the cells. Potassium will go into cells, inside the cells. But when insulin is less, opposite, potassium will come out of the cell into the bloodstream. Okay, understand this concept. If insulin is more in the bloodstream, potassium will go into the cells. But when insulin is low, potassium will come out of the cells and it enter into the bloodstream. Okay, and that will cause metabolic acidosis also, right? So initially potassium appears elevated. So initially potassium appears elevated, but total body stores are depleted. When you check the total body total body potassium level, it will be low, because DKA patient will be having more, fluid loss, right? When fluid loss is more, potassium will also be lost in it, right? So that total body so potassium will be less. A child with nephrotic syndrome has edema and proteinuria. Which lab value confirms diagnosis? So yesterday we have read about the nephrotic syndrome. Nephrotic syndrome symptoms I have told you: hypoalbuminemia, albumin will be lesser, increased proteinuria, massive proteinuria will be there, okay, and edema. So here, in which lab value you will confirm the diagnosis? A, serum albumin less than 2.5, yes, and creatinine, no, it is not associated with it. HB also not a WBC. So the answer is serum albumin. Next, which drug is antidote for magnesium sulfate toxicity? It is very direct question. It is calcium gluconate. Okay, magnesium sulfate toxicity, calcium gluconate. Naloxone is for opioids, and atropine will be giving for brady, also ognophosphorus poisoning, and sodium bicarbonate for acidosis. Next, a patient with COPD receives high flow oxygen. COPD patient receiving high flow oxygen suddenly becomes drowsy. What is the cause? So if we say oxygen toxicity, is it correct? No, because oxygen toxicity for to happen, the patient has to be exposed to it for a longer time. Okay, in high flow oxygen, the patient has to be exposed for a longer time, so it won't be oxygen toxicity, but there is a chance for carbon dioxide retention because of high flow oxygen. Usually COPD patients, there won't be enough carbon dioxide coming out of their lungs. Carbon dioxide will be accumulated inside. I have given a clear description about it in the ventilator series. Okay, once you check it. So carbon dioxide retention. So this one is also a very easy question. ECG finding in hyperkalemia. Yesterday I have discussed tall peak T waves. Also this is the earliest sign, tall peak T waves, and wider QRS will be the later sign, and then cardiac arrest will be there. Next, priority intervention in tension pneumothorax. In case of tension pneumothorax, there will be accumulation of air inside the pleural spaces, and there will be deviation of trachea. Yes, tracheal deviation also be there. It is a severe, it is a life-threatening condition. So what we have to do is chest X-ray. We don't have that much time to take x-ray and then to rule out. Okay, anyway, if they find out as tension pneumothorax, the only option is needle decompression first and foremost. Okay, oxygen mask, it won't help. IV fluids, it won't help. Next, which insulin acts fastest? It is rapid acting insulin. Regular insulin is a little slower, right? Regular insulin acts slower when it is given in subcutaneous route. Yes, and Lispro is a rapid acting insulin. Yes, Lispro is a rapid acting insulin. So it will be given a few minutes before the meals to prevent the postprandial, hyperglycemia. And NPH is intermediate acting, and Glargine is long acting. So here the fastest one is Lispro. Next, a patient on warfarin has INR 5.5 without bleeding. Yes, what is the management? The patient is on warfarin therapy. As I said, if the patient is on warfarin therapy, we have to check PT-INR. Yes, so INR, the normal INR range is 1. INR should be 1 for a normal patient. If the patient is taking warfarin, at least 2 to 3 should be maintained. INR should be 2 to 3. If the patient is having any mechanical valve replacement, okay, at that time we can leave up to 2.5 to 3.5. It's okay. Okay, it's a therapeutic level. It means the warfarin effect is working. That is okay. But if it is more than 5, it is a high risk. INR should not be more than 5. It is high risk for bleeding. Okay, here without bleeding, right? So a patient doesn't have any bleeding manifestation. So the option continue same dose, no, because it is already INR reached more than 5. Okay, it's not inside the therapeutic level, so we can't continue the same dose. Stop warfarin temporarily, yes. We should not give warfarin now. We have to withhold. Give protamine sulfate is the antidote for heparin, not for warfarin. For warfarin, the antidote is vitamin K. Vitamin K is the antidote. Immediate transfusion, here no bleeding manifestation, so transfusion not needed. And vitamin K is also not needed because bleeding manifestation is not there. Without bleeding manifestation, if we give vitamin K, then the warfarin effect will be, warfarin resistance will be created. So we won't give vitamin K without bleeding manifestation. So yes, we have discussed 13 questions today. So we'll be continuing in the next video. Until that, bye bye.